me, but I plan on attending, so I'm just going to attend.
Thank you, Liz.
Thank you.
So recording is live, and I will go ahead and begin a meeting now.
Great. Starting to see our friends climbing aboard.
That's everyone. Good afternoon, everyone. My name is Guy Nagby. I'm with the Institute for Credentialing and Excellence, and thank you for joining the public member networking call. I'm going to give attendees about 30 more seconds before we start, and then I will transition to some house cleaning, and then I will pass it off to Becky. Looks like Michelle. Okay. Before we get started, can I ask everyone to turn their cameras on, just for cooperation? And you can unmute yourself if you need to ask questions, or you can use the chat feature. Once again, good afternoon. Thank you for attending today's I.C.E. Public Member Networking Call. My name is Guy Nagby. I'll be serving as your technical support for today's conversation. If you have any issues, please send me a private chat, and I will follow up. A few ground rules for our conversation. If possible, we ask for you to turn on your camera. We ask for you to mute yourself if you're not actively speaking. You're welcome to ask questions by just unmuting yourself, as I just stated. You can also raise your hand in the Zoom, and one of the moderators or myself will notify the speakers to give you an opportunity to speak. If you're more comfortable using the chat, that's fine. You can go ahead and put your message in the chat, and I will pass it along to the speakers, or I will recite it. Finally, the conversation will be recorded. If you have any concerns regarding this, please feel free to send me a chat directly. We have an hour scheduled for this event, and we may not go over that time. But if the conversation continues, comes to a natural close, then earlier, Shorty, this is my first time today. We do welcome that too. With that said, I'll now pass it over to Becky Laboon. I'm sorry, Becky, did I get that right?
That's right. That's right. Thank you, Guy. And greetings, everyone. Welcome to our quarterly network call hosted by the I.C.E.'s Public Member Committee, of which I'm the current chair. And this topic today is one that's very dear to my heart. Having been the co-founder, along with Dave Swankin, of the Citizen Advocacy Center, which for more than 3 decades provided resources for public members on health professional licensing boards and certification bodies. And one of the services that we provided was an annual meeting where public members gathered together and shared experiences, and they talked about the issues before their boards. And there was a constant frustration among these public members that the boards on which they served, they didn't think were taking sufficient concern with demonstrations of current competence at the time of license renewal or certification renewal. So CAC held meetings on that topic, and we produced a number of publications which are available on CAC's website. Although the organization is no longer active, the website is still live, and it's www.cacenter.org, and you can find a number of publications on continuing competence. And the environment has improved quite a bit over the years. And in fact, certifying bodies tend to be more active and creative in their recertification policies than licensing boards are. Certifying bodies, being part of the private sector, they can be a little more nimble and a little more creative in how they address the topic. And I was also a public member of the of NCCA, where I paid special attention to the recertification requirements in the NCCA standards. And when I was there years ago, most of the applicants for accreditation relied almost entirely on seat time CE as the requirement for recertification. More recent iteration of the standards require a little bit more of them, both in terms of the content of their recertification policies and also in how they explain how the recertification policies actually lead to a demonstration of current competence at the time of recertification. This morning, we are going to hear from two experts in the field of credentialing, and with special attention to continuing competence. I've known them for a long time. They've been in the trenches working to achieve more meaningful recertification and relicensure requirements. And now they are part of the leadership of a brand new organization that has been created for the purpose of encouraging and rewarding advancements in continuing competence. They don't need much introduction. Catherine Dower is the immediate past public member of I.C.E.'s board of directors, and Grady Barnhill, his long history of contributions to the world of certification was honored recently when he was given the I.C.E.'s Lifetime Achievement Award. I'm going to turn the microphone over to the two of them, and if they want to say anything more about why we should pay attention to what they say to us, I'll let them do a little self-introduction. Grady and Catherine, take it over.
Thank you. Grady, do you want to go first? Do you want me to start?
I was going to let you start, but I was going to ask if people can see our screen yet. People able to see that? Okay, great.
Yes.
Yes.
Thank you.
All right. Well, I will jump in then. I saw you start to open your mouth, so that's why I wanted to defer to you. So I'll still say good morning because I am in California, and good afternoon to everybody as well. I'm Catherine Dower, and thank you, Becky, for that terrific introduction and warm welcome. In addition to serving on the I.C.E. Board of Directors as the public member, just finishing up my term in this past year, 2023, I also served on NCCA. I've served as a public member on many certifying boards and commissions. I've spent 30 years doing research and policy around health professions regulation in particular, looking at licensing issues. One of my through lines in all of that work has been bringing a public perspective, a public protection perspective, and trying to increase access without compromising safety and quality to healthcare services across the United States and internationally. One of the key issues, as Becky mentioned, for me and for many public members and public organizations, is this issue of continuing competence. I remember first clipping, like literally cutting out a comic strip. It was a Gary Trudeau Doonesbury comic strip in the 1990s about some doctors who weren't, they didn't have many patients, and they were talking about the challenges of maintaining competence. So they were operating on melons to maintain their competence. And I cut out that comic strip. I created an overhead projector slide that we used in our presentations with that. So just giving you some background on how long I've been doing this and how concerned I am with it. So I'm delighted to be part of ISACC now, and I'm going to jump right into the second part of our question for the title of this this session. The session is titled, "What is ISACC and why does it exist?" I'm going to talk about why does it exist. So Grady, if you could advance to the next slide, I'll start in. So the big reason why we are concerned with ongoing competence is this issue of skill decay or skill fade. Those are two terms that are currently used in the research and policy world. Both of them are a little bit awkward. It's skill decay reminds me of some dental issues, and skill fade sounds like a cool haircut. But I think the challenge is that we are increasingly seeing evidence and research showing that our skills as professionals, as humans, decay over time and for various reasons. or fade over time. And so there's a challenge with that. The biggest concern is disuse. So that is, if you're not practicing your clinical skill for which you were licensed or certified, those skills can fade. The competence in those skills fade off, and sometimes fairly quickly. Some of the most recent research shows that disuse for as short as 2 months or 6 months can really have an effect on some of the competencies or some of the skills in some professions. Even if we're not stepping away from our profession for some reason, that is, we're not subject to this disuse issue. We've got age on our side, or time, and we know that some skills decline as people age, as we grow older. Over time, there's some things that we just don't know or do as well. But it's more complicated than that. So it's not a simple algorithmic equation. There's differences in complex versus simple skills. There's a lot of difference in physical versus cognitive skills. And even within cognitive skills, there's some differences within all of those. There's a lot of differences among the professions, among individual jobs, and of course, among individuals. Some people maintain their competencies better than others, or maintain some competencies better than others. There's also this issue about retention and improvement of skills, especially as people specialize. They might get better at some skills. And ongoing reviews amongst peers seems to have a very positive impact as well. And then this question of reacquisition of skills has come up. This really came to the top of the issue list during COVID, when many states asked recently retired people or people who had been out of the workforce for a while to come back to serve in the workforce. And there was some concern about, well, how do we assess whether these people are still competent? Is there a cutoff point? Is there a refresher course that people can do? And then the flip side of that was that many people, many professionals across all the professions, including healthcare, took time off during COVID, either because they got sick or some of their family members got sick and they were taking care of them. And then they wanted to re-enter the professions. And there was a lot of confusion about what to do to make sure that those people were still competent. And many of the research, many states offered waivers actually to continuing competence during that time to make things even more complicated. So it wasn't clear whether people had to continue their CE and whether and how they could refresh their competencies. This little table I have, this little graph on the right side of the slide, is for illustrative purposes only, but I think it's helpful to share this picture of why we're concerned. So the graph shows competency going up from -3 up to 6 on the vertical axis, and then over time on the horizontal axis. And that red line at the level 4 point is this hypothetical minimal competence line for this hypothetical profession that I'm going to use in my example here. And that dotted vertical line is the point in time when someone is certified and licensed in this hypothetical profession. So they're certified and licensed, they're tested, they finished their education, they're tested, they're certified, and they're licensed at just over that minimal competence. That's what we test people for. And then as things go forward in time, I've got many illustrations here with some people in some professions. The green line is the first example I'll show, actually increasing their competence because they specialize in something in their profession. So their competence actually gets quite good. It's increasing over time. There's a couple more people. The orange and the blue are examples here, or not people, groups of people, cohorts of people who maintain or slightly improve their competence by, their practice, or by doing CE, or by going to trainings for doing something more. And then some of the others start to decline almost right away. Maybe those people just crammed for those tests, but didn't really learn the information. Maybe the work that they're doing wasn't really tested by the initial test and licensing exam that they went through. And then things progress over time with various people going up and down across those lines. And we do not really assess where anyone is in any of those lines as people get recertified or relicensed throughout their careers. This is the big question. And there's a lot of evidence that will show that over time, many people are dropping below that minimal competence. Many people are going above it, but many people are dropping below, and we don't know who they are. I could have added, the 2-year CE requirements across that timeline. It got a little messy and complicated, so I didn't include it. But those 2-year or 3-year or 1 year, depending on your profession and your whatever, CE requirements for recertification and relicensure, often, as Becky mentioned, are just because you sit in a chair, you go to a didactic program, you do your hours, but there's no test of competence. There's no assurance that you are addressing your shortcomings, that you're improving your skills or maintaining your skills. So that's the image that I like to share about why we're concerned, because we just don't know, but the research indicates that a lot of people are probably dipping below that minimal competence line. Let's go on to the next slide, because one of the things that I do is track many of the policy trends. Could you advance to the next slide, Grady? I've got just a couple of points I want to make about some policy trends and developments. So a lot of us hear the headlines, either in our local, news feeds, whatever we're tracking, or within specialty areas, that some certification requirements or recertification requirements are being eliminated or they're decreasing in some states and some professions. So the headlines in the past, several months, I saw nearly half of the companies say that they plan to eliminate bachelor's degrees in 2024. That was a story that came out in late 2023. That's kind of like, that is pretty significant. Another headline that I saw was that Montana is considering eliminating CE requirements for registered nurses. So there are some headlines that come out that way, and it kind of makes us take notice. Usually, the reason they're headlines is because they're unusual. Those don't happen that often. So they get a little bit of airtime, but they don't happen that often. They don't happen in many professions. For the most part, certification and recertification requirements are being maintained across all the professions, across all the states. And in some cases, in fact, they are increasing. There's also headlines about specific professions getting, having to take more courses. I just saw a big story about police departments, for example, are required to take a lot more CE recently, in recent months and years, after many of the horrible incidents that were recorded and shared that we all saw in the news over the past few years. So many police departments are actually increasing their CE requirements and hiring requirements too. So overall, there is this maintenance of the current way we've been doing it. So we continue to have licensing requirements, we continue to have certification requirements. And in fact, in many cases, they're increasing. But there are some examples where they drop it. That's always notable. And we should pay attention to that, because it often is based on the evidence that's showing that the way we've been doing it doesn't really have an impact on competence. Now, one thing I do want to point out is that even more important, that is the fact that this recent DOJ, Department of Justice, the FTC, that's the Federal Trade Commission, and Department of Health and Human Services at the federal level. So this is the US, not at the state level, this is federal level. They opened up a joint online public portal called healthycompetition.gov. And that is for anyone to file a complaint or concern about what they think might be unnecessary certification requirements. So this is interesting, because the trend here is that some probably professionals are going to file the complaints. I don't think there are many public members who think that that the certification requirements are too much or are resulting in an anti-competitive state of the situation. But professionals are complaining about the certification requirements being a burden. So that's notable. This is a new thing. This is an interesting combination of groups that are doing this. They're pretty large and powerful in many ways. So it'll be interesting to see what comes of that. And they specifically called out as an example of something that might be a concern, the unnecessary certification requirements for physicians. That also is noteworthy, because physicians in medicine is often the leading profession in much of this work. And to call them out as maybe they're being too The burdens are too much for them, will have some trickle-down effect on many of the other professions, if in fact that's the case. I will also say that in the big picture, in terms of licensing especially, it's really, and certification, it's really important to note that the meta research is that over the past 60 years, the number of jobs requiring an occupational license or government approval of some sort to practice has grown. So this is the number of jobs has grown in America from 1 in 20 to 1 in 4. So the movement over time has been to expand licensing and certification requirements. I just want to keep that in mind, even though there are these little blips going on. And the meta studies also about the quote deregulation or delicensing trends, it's just not happening. The little one-offs that pop up here and there that get squashed down by there's often a very stringent response to those or reaction to those by the PCC, by other groups, and by many of the professions. Those are getting squashed down pretty quickly. So there's very little deregulation or delicensing or removing certification requirements. However, again, this point about the DOJ setting up their portal is really interesting. And I will say the big learnings and the bottom line on this slide, the learnings from all of this is that we don't have a lot of evidence on the value of certification or recertification and these efforts to have CE requirements. We don't have much evidence about the value of the current way we're doing that for the profession or the impact on the public. And that's where we have concern. So when they bring up these little one-off efforts to question the way we're doing CE or the way certification is being done, it does raise a good question. What's the value of the current way it's being done? And oftentimes there isn't very good evidence. We do know that the current approach is a burden to practitioners in terms of time and money. That often translates to more cost to the consumer and to the public, the patient, the client. So we do know that, and the professions don't like it often. They like the idea of maintaining their competence, of course, but they don't like the way it's currently being done. It feels burdensome. And the big takeaway is the value of research, because we are learning more and more every day. There is some good research going on. It makes sense and it's valuable to pay attention to that. So let's go to the next slide. This is one of my favorite quotes by Zora Neale Hurston. Research is formalized curiosity. It is poking and prying with a purpose. So this is why we've put together I.S.A.C., because we think it is worth formalizing curiosity to come to some a systematic approach to raising our questions and applying our questions to the research field. Let's go to the next slide. And this brings me around to the role of I.S.A.C. So the role of I.S.A.C., we have our mission statement and we have all of those things, but this is how I present it, and this is why I'm involved in it. Our roles are to get curious, to track, to conduct, and to help promote research about continuing competence, about what's been done in the past, what's currently going on, what could be done in the future, how it can improve the practice for professionals and improve the services or the offerings that are given and the care that's given to patients and clients and consumers. Another role of ours is to acknowledge the pioneers who are doing good work. So we hope to reward and to shine a light on those who are the leading edge individuals and organizations and the early adopters of good and promising efforts to improve continuing competence and continuing education. And we want to develop the community. We want to help be the organization that convenes so that people can discuss and explore more, because there are a lot of questions. There's lots of learnings to happen here. I want to emphasize, and I know Grady's going to talk about this more, prioritizing the public member role. I.S.A.C. grew out of a number of people who were public members on certification bodies. It was discussed at the public member committee that I.C.E. sponsors, and it really grew out of that. I continue to hear people who are concerned about CE and continuing competence, who are public members or from public advocacy groups. And I want to make sure that we prioritize the public member role as we develop our community. So with that, I'm going to, I think the next slide might be the transition slide to Grady. Oh yeah, we have some stay in touch. We'll return to this one, I hope, at the end too, but this is some information about how to get in touch with ISACC, where we are, how to reach us electronically. And with that, I will pass the baton to Grady. Thanks for your attention so far.
Thank you, Catherine. And I'll say these are the web addresses and email that is kind of a work in progress. So please be patient with us as we are under construction, but these will be our addresses where you can find us and find out. Move along to questions about, and this is something Catherine's already alluded to. But the question is, why should we do something rather than nothing? It's kind of, the question would all rise. Why not just do CE? That's a constant question. So I would sort of take us back to the turn of the century. Now that we're old, we can say turn of the century a lot more, but a lot was happening at the turn of the century. A sort of seminal study came out from the Institute of Medicine in 2000. It was called To Err is Human, and it focused on medical errors. I think it's fair to say that the medical specialty boards do more with continuing competence than almost anybody else. They take it very seriously and make an effort. So if their efforts are not paying off in terms of reduction of errors and that sort of thing, then certainly that would give us concern for the rest of our credentialing landscape. That in that 2000 IOM study, they pointed out that medical errors were responsible for 40,000 deaths per year, which was an astounding number. Not something that many of us had heard before. Was close, at least at the time, to the number of deaths from automobile accidents. So it's a significant number. An article in 2016, the BMJ, used to be the British Medical Journal, they suggested those numbers were an underestimate, and in fact, the number of deaths due to medical error was more like 250,000, that it was the third leading cause of death in America, as a matter of fact. Now, those numbers obviously can be debated and argued about, but the point is that everything is not perfect in medicine, and probably by extension in almost every other group that has a significant risk. A study that had looked at autopsies found that as many as 40,500 adult ICU patients died with a misdiagnosis every year. So again, back to that serious number of errors. And this is a systematic review reviewing autopsy. So this is, if you do an autopsy, you've got a pretty good idea of what actually was the problem with the patient. You're not another 2015 IOM study. Quote from that is that diagnostic errors are a significant and common cause of problems in healthcare, and most people will experience at least one medical error in their lifetime. So kind of brings it home that this is something that may affect all of us. So the more that we can do to help ensure the continuing competence of practitioners across the board, I think the better off we'll be. Looking at malpractice, which I think is another proxy for medical errors, but if you're paying out a malpractice claim, chances are that there was some sort of problem that was operable there. You can see that the diagnostic related errors are the number one most common root cause of malpractice claims. The gray bar indicates the amount paid out. The red bar are just the numbers of cases. So you can see that more money is paid out because of diagnostic related issues than anything else. And I think it can be argued that misdiagnosis is more closely related to medical knowledge and clinical skills that are two things that we really focus on in terms of continuing competence programs. So I think it's a good reason to keep working on those things. Here's a slide that violates every rule about PowerPoint slides, I think, that have ever been made, but won't ask you to look at all those words, but just if you would focus on the left side. This is from a pan-Canadian study and a 2019 study that looked at factors that supported as well as were a risk to competence in practice. And you see three significant factors listed here. The first two are rather related: age and practice experience. Those two are very conflated, obviously, but it's very clear from that data, as Catherine alluded to, that aging is it's very negatively impacting patient outcomes. I'm sorry. It's the same for practice experience, with 48 of 62 studies reporting decreasing performance with increasing years in practice. And I should say, anything that looks at practice or continuing education, that sort of thing, you're going to need to look at systematic reviews or meta-analyses to get a good idea of what's going on. You can find any single study that will support anything you'd like to see. But if you look at the trend overall, it becomes very plain that this is a very well-supported factor. An interesting one that I mentioned down here at the bottom is exam scores. This makes psychometricians a little queasy as you talk about using scores maybe for things they weren't exactly designed for. But you see that there's a lot of correlation between exam scores, that they're very predictive of practice performance. So you see associations found with prescribing, screening, consultation rates, complaints, and assessments. So that may be something we want to look at and consider in terms of doing something with in the future. This is one of the reasons, again, coming back to Catherine's call for better research, we're starting to see more and more things that might be of use in trying to create better continuing competence programs and make those relevant and meaningful. So we'll move along to many of us that are long in the tooth are concerned about what might cause our decline in performance and our knowledge. We've begun talking a lot more in the research about two types of knowledge, System 1 or System 2. The System 1 or automatic learning is what you get from experience, and it results in crystallized knowledge. For example, you may see a constellation of symptoms over and over in your practice, and you begin to have automatic knowledge that, oh, that means that's type 2 diabetes when I see those signs and symptoms. It sort of happens automatically, but it can be a little resistant to change, which is why sometimes we have an increase in practice efficiency as we can rely more on those pattern recognition behaviors. But then as those pattern recognition behaviors become outdated, we begin to make more errors, and it is sometimes hard to update that automatic knowledge. So that's something that we need to be aware of, and we're seeing increasing research in those areas. And so the age-old question, why not just require completion of continuing education? One of the, again, big studies at the turn of the century, 1999, D.A. Davis et al., a big international study looking at effectiveness of CME in the most cases. It just said didactic sessions do not appear to be effective in changing physician performance. And I should point out, we're not saying all CE is bad. It's just that untargeted CE that doesn't have any special features, it's not interactive, or it doesn't have multiple sessions, et cetera, is just seen usually as ineffective in looking at changes in physician performance or in patient outcomes. Another quote, didactic presentations and printed materials alone have little beneficial effect on these outcomes. It's a 2005 study. And another IOM study, 2010, indicated the CE system as it is structured today is so deeply flawed that it cannot properly support the development of health professionals. So there's a very clear call to action with these rather large studies. And you see this reflected too in our NCCA standards that Becky had worked on and helped us with. But you see in the commentary for Standard 12, it calls out some of the typical concerns with regular non-fancy CE, that sometimes those limitations of CE include self-selected CE, focusing on convenience and cost over need, if it's sometimes point-oriented rather than learning oriented, that you might have a commercial or sponsorship bias. And they're asking now to document how that program that you have evaluates whether the CA activities support the continuing competence of the practitioner. So we're seeing more and more requests that we do a little bit more with our continuing competence programs rather than just good old CE. So another thing that we talk about, particularly related to CE, is that a lot of the systems are set up so that the practitioner does a self-assessment and decides what they need for their practice. It's kind of logical that the individual would know what they need to study. There's one problem with that, and that is that, to summarize, those practitioners who have higher ability tend to underestimate their abilities, while those who are at the lower end of the ability scale tend to overestimate their abilities. And it's something that's problematic when you're trying to evaluate what you need to learn. It works best for those who need it least. So the Dunning-Kruger effect you'll hear bandied about a lot now in research, that where folks that are with lower abilities are overestimating where they are and what they need to learn, which is obviously a concern. Another factor in why we should do something rather than nothing is that the public expects it. I know that NCCPA, where I used to work, the physician assistant certifying body, contracted with CAC and Becky and others there to conduct focus groups in Maryland, looking at what the public expected of continuing competence programs. And it's consistent with what NBCRNA, the nurse anesthetist certifying body, recently found with a Harris poll, that 85% of the public believe it's important that healthcare professionals who are going to treat them have an independent body of healthcare professionals to evaluate their skills and knowledge to certify that they are competent. So everybody's kind of expecting that we're doing a lot to ensure the continued competence of our practitioners, and are surprised when they hear how little we do, if at least in terms of some of the focus groups. So what to do now that we've had all the scaremongering? What can we do about this? How might we address some of these issues? I'd like to give a shout out to the American Board of Medical Specialties. They've done some groundbreaking work in this area, and I would refer you all to this conceptual foundations document that documents a lot of the work that and research that they put into recent revision of their continuing competence program, their maintenance of competence program that now is a certification maintenance program. There's some takeaways here that you'll see, but just wanted to get this document out there for you to reference because it has a lot of good learning. From that, ABMS launched a new process that is called longitudinal assessment. And I promise not to talk too much about longitudinal assessment, but I did allow myself 2 slides to share with you feedback that we have. This is feedback from practitioners where NCCPA, working with physician assistants, we had a 2-year pilot study with longitudinal assessment. And the main feature of longitudinal assessment that I'll touch on, I won't describe the whole program, but the primary feature that's really helpful is that in this format, you look at a multiple choice question, you answer that question, and you immediately find out if you got that answer right or wrong. And more importantly, you find out the rationale for why each choice is correct or incorrect. So it turns each question into a wonderful learning experience. This has led to a whole host of research that supports test-enhanced learning, for example. There's a great deal of evidence showing that test-enhanced learning is more easily acquired and is more durable than just studying alone. These are perceptions, I should say, of the pilot test participants over a 2-year period. The big blue bars, the darker blue ones, are for a strongly agree. And you can see the 3 biggest blue bars, which are my favorites. They kind of reinforce that notion that the first one there, receiving immediate feedback on each question in the Pioneer pilot helps me learn. So it does underscore that looking at those questions and seeing how you did on them, understanding that question and why each choice is correct or incorrect is a tremendous learning experience. So that's one of the things we're excited about as one possible way to address continuing competence. This is another just slightly depressing slide for those of us that are had a little gray on top, and that is 3 different performance curves here. The depressing thing is that you see the blue line at the bottom represents the late career performers. You can see that their average performance is lower than the performance of the other folks. The axis on the bottom, the x-axis going from left to right, represents the quarter. This was an 8-quarter study. And so the wonderful takeaway from this slide is you see this ability curve is increasing over time. So we see that the average ability of the participants right at the beginning is starting to go up as they participate in this 2-year program. So we do have some demonstration that learning is occurring, and that's a very exciting thing. This is data that we don't have available, at least in many other systems. So it's kind of an exciting thing. Another response, as Catherine alluded to, is in terms of what to do, and we hope that we'll be able to help shine more light on this issue. I think if we could get to a place where we're spending as much in resources on continuing competence as we tend to spend on initial competence, I think we'd be in a much better place. We do a great job with initial competence with our item bank development, item writing. We have fancy psychometricians that are doing great things, equating forms and doing standard setting. There's great psychometrics that go into initial certification, but we tend to be a lot more relaxed, shall we say, when it comes to ongoing certification. So there's hope that we'll do more with that. This group was announced. We incorporated in April of 2023, and the group I.S.A.C. was announced in May and at the International Regulatory Research Day in Dublin, Ireland. And then again later in 2023 at the November I.C.E. exchange, Denise Rusendahl announced our partnership that we are looking forward to. We have established a document that's an agreement of cooperation with I.C.E. And so we're looking forward to doing more things with I.C.E. as well as other groups in this space, like CLEAR, perhaps FARB, or other groups that are in this regulatory space. We have this here, you see our board of directors that I think is a great group of folks. I'm excited that we have representation, not only from the US, but from Ireland and England and Canada as well. So I do think we have a lot that we can learn from other countries, not just the US. They have some different approaches to continuing competence that I think we can learn from, and we're excited to include them. We look forward to doing more in the way of having an awards program to reinforce those groups that are doing research, as well as those that are doing development of new programs and implementation of new programs, as well as stimulating research that we look forward to being a gathering or connecting organization. As an example, Becky, who has been in the business a long time, knew Bob Ossoff, I think is his name, that was one of the progenitors of the national database for disciplinary database. And he was responsible for developing a public use database that takes data from that national disciplinary data bank. And that's something that can lead to some great research opportunities. We've connected that data bank and the use of that database to folks that have access to SPSS. It's a very large data bank, and you can't just download that into your Excel spreadsheet. It takes a lot of horsepower. So we're looking forward to getting some interesting research. The picture of malpractice and what goes wrong so that we can figure out more about how to keep things right. So we're excited about that. And these are just some references that we have as part of this presentation that should be made available to you. And we'll leave this speaker contact information up for you, as I believe we've allowed time for some questions. Should we have anyone who would like to ask us questions, and we're happy to do our best to respond.
Yeah, Grady, this is Wallace Judd. Doing
Hi, Wallace.
a double-blind study for evaluating the competence of practice of physicians, I think would have ethical problems, because your control group would be unethical. How do you deal with that, sir?
Right. It's yeah, nobody wants their grandmother to be in the control group in that kind of study. So you have to look for opportunities that are already there. For example, some of the values of certification research look at groups that are certified versus other groups that are not certified. You can see that in the medical specialty world, where certification is not required for practice. Other opportunities we look at, and a lot of this is associational, it's not a randomized control trial, but a lot of the CE research that we referenced is associational. In other words, we'll look at different types of CE and look at different outcomes for either physician practice or patient outcomes. And then we'll just look for an association with a type of CE. Some worked better than others. For example, in that D.A. Davis study I mentioned, it's a great study, and they point out types of CE that are more effective. CE that has multiple sessions, in other words, more learning opportunities. CE that includes things like reminders. If you send out an email after the CE lecture that summarizes the points, or sometimes they would have charts, little roll-up charts that you can put up on the wall in your practice that have a flow chart for activities, anything that helps mentally rehearse that knowledge again. CE that is interactive, and by that I mean truly interactive. For example, practicing a clinical skill if you're a psychotherapist with your somebody else in the audience, not just turning to them and saying, "What did you do on your summer vacation?" So I hope that addresses your question, but you're right. The true randomized control trial it's a bit of a problem. Incidentally, a lot of that research, the D.A. Davis research, did look at RCTs that were out there in the literature. So that it's old. It's from 1999. It was a very good study, and that group has done a lot more research too since that time.
It looks like you have more hands raised. I think Ellie, you were next. Do you want to come off mute?
Sure, thanks for taking my question. I'm curious, in the pilot study that you're doing with physician assistants, you showed that nice graph demonstrating improved competence. Do you have any data to show the impact on patients, such as fewer, medication errors, malpractice lawsuits? Are you tracking that kind of thing yet?
Not yet. No, that'll take some time, clearly. And this is that was a 2-year pilot. They have just implemented the longitudinal assessment program, so it's still new. We're just excited to see the demonstration of learning that we haven't had before. But yeah, it'll take a while to connect that to outcomes. It's tricky, particularly with patient outcomes. Usually the first thing we'll see on the radar is compliance with practice guidelines. You can look at that data and see, well, how are they doing in terms of the latest hypertension guidelines? Have they made the switch to the new values now that they've redefined hypertension? So that I hope that answers it. We're still in the infancy of that.
Yeah. Who do you find to be your most effective collaborator in having access to that type of data?
Most effective collaborator, do you mean research or in terms of data sources, or?
Yeah, so is a health system giving you access to their EMR, or how are you collaborating to find that data?
Yeah, that's a challenge because of HIPAA and privacy. It's one of the challenges with the National Practitioner Data Bank. While you have an individual record number for each individual, you can't link that to a particular practitioner. So at least with normal avenues, because of Becky's connection with Bob, we might be able to see if there's some workarounds with that, but obviously they have to be very careful with de-identifying the data, particularly with patients, but also practitioners. So that's
I will add to that I am aware of some systems that internally have been doing their own research, not always publishing it, although sometimes they will publish abstracts and kind of summaries, but there are some healthcare systems that are looking at their own internal practitioners, and they're looking at correlations between competence and poor outcomes, and trying to intervene and finding ways to address or intervene at earlier stages to help prevent further problems. So there is some research being done within private sector systems, systematic health systems. I know about that.
Mm-hmm. Thank you.
Thank you.
Brady, this is Wallace again. I don't see another hand.
No.
You might be interested to note that my dissertation at Stanford in 1981 was on self-appraisal and came to the same conclusions that you had just discussed here. People who are very competent question their own competence, and people who are incompetent inflate their own abilities. So that was a long time ago, but
you're ahead of your time, Wallace. Thank you.
Clean and clear study.
I think Benjamin had his hand up.
Yeah. Let me first offer my appreciation for your presentations. I think it's such an important area for all of us, and certainly me, having got my license as a psychologist 45 years ago. But I wonder if you could comment on the potential impact of AI. You know, I suspect that in a short number of years, continuing competence might mean, at least in part, the degree to which we can effectively utilize AI for everything from differential diagnosis to, treatment planning, et cetera, in ways probably that we can't even imagine today.
Yeah.
So if we set aside, all of our criticisms of AI, at some point it's going to become so effective, and the error rate will be so small that it'll be utilized in all kinds of ways to impact our continuing competence.
I'll start and then let others join in. I think you're exactly right, Benjamin. That's I think where we're headed. I think we'll have AI agents that'll be doing a lot of this research. I know the American Board of Family Practitioners has looked at harvesting data from the EMR, from the electronic medical record. So the idea would be, imagine how nice this would be for the physician. He doesn't have to enter anything. A web crawler or an AI agent will crawl through the data from that medical record that he's created and look for patterns, look for compliance with practice guidelines, look for outcomes. Are the diabetes blood serum levels, are those values in alignment with what your targets are? See how well these practitioners are performing, and then they would have the horsepower to maybe look back and see, well, what kind of CME has this person participated in? Why are they so good or so bad? So I think we'll see a lot more of that kind of research enhanced by the AI agents, because it's maybe a little too much work otherwise. Others care to respond to that?
I actually think that was a great answer, Grady. And I think that AI is also going to significantly impact the way we test people, the way we provide certification, ongoing certification, licensing. It's going to shift. It's going to shift the workforce tremendously. So I think you did a great answer, though. I wanted to also address, I know we're running short on time. Zoe Wang's question in the chat box was, what about individuals returning to practice after an extended period of absence? They wouldn't have participated in CE. What are the evidence-based ways to assess, ensure their competence? Many desire alternatives to, quote, redoing the whole certification process And many regulators are also under pressure to reduce barriers and bring people back. I'll start with the last. I have actually done some work in this area a little bit. I've been supporting or working in collaboration with a researcher at in Michigan, doing some research for physical therapists and this returning to practice after a period of disuse, essentially. There are many professions and states that are trying to expand access by increasing the workforce, reducing barriers. So some people, as I said, during COVID especially, waivers were in place. Many people came back into the workforce under a waiver process of one sort or another. CE requirements were lowered in many cases. They've mostly been put back in place now, but it was an interesting, what do you call it, an organic experiment that we could look at. But there is a lot of question about people coming back to practice after not being in practice for a while and not even having done CE, which we're already critiquing the CE. But if you haven't done that, if a professional hasn't done even CE and they've been out of practice for a while, the states and the professions vary tremendously on how much time you can have off without demonstrating competence again. In some cases, as long as you keep paying your fees and maintain your license, you don't have to demonstrate competence ever, and you don't ever have to attest to the fact that you haven't practiced for a while. In other cases, if you actually have let your license lapse, the states and the professions vary as to how long you can be out of compliance and not have your license before you have to start completely over again. In some cases, it's only a couple of years. In other cases, that's up to 5 years or more. So it really varies tremendously. And when I've actually looked at the policies and the statutes and the regulations on this, and it was a lot of political compromise. It wasn't based on any evidence that showed that people were still competent after 2 or 3 or 5 years. It was kind of a political compromise. So this is an area that needs a lot more research. And it is possible to assess how quickly people fall out of competence on certain things. You can assess which skills in your profession fall off the quickest and then create programs. And medicine has created a number of programs to help people get back into practice if they have had a lapse in practice for whatever reason. And so that's a good model to look at. Many of the other professions are still developing those options. So that's a whole area to look at. It's a great question. I think that's a lot more work to be done in that space.
Mm-hmm. I've done some work too on the assessment advisory group for a British Columbia group that the Nursing Community Assessment Service that does assessments for people re-entering practice and also foreign educated practitioners to help determine if they are equivalent to Canadian practitioners. So that's another exciting way to do it. Just make that assessment and see if they're up to snuff, and it can be helpful for a number of things in prescribing CE that they might need. And I think we're about out of time.
We are about out of time. And thank you very much, both of you, for a very...
Thank you.
Guy,
could I ask Guy to post or send to the attendees the link for the public member website, because people are asking about that and I don't have it on hand right now. So at your convenience, Guy, could you post that or send it to the attendees of this session?
Yes, I was about to say that the recording of this session will be posted on the public member resource page. So you can all access that. And you all also have the contact information for Catherine and Grady if you want to follow up with any kinds of questions. Mm-hmm. And thank you very much again for participating in this. And hopefully you'll come to other quarterly calls every, March, June, September, and December. We hold the public member committee holds one of these sessions on a topic of interest, I think, to probably everybody within ICE. So thank you very much. And we'll see you again.
Thank you very much, everybody, for participating.
Thank you.
Good day, everyone.